palliative care in progressive end organ failure. She is a co-author of joint guidelines of ISCCM with IAPC for EOLC in ICU and many others. Madam, the stage is yours.
Thank you so much. I'd first like to start with thanking Dr. Lokesh, everyone at Manipal for inviting me to be a part of such a wonderful meeting. It's been a very enriching experience to listen to all the wonderful talks, starting from the double danger of diabetes to the lungs and all the infectious diseases specialists, the rheumatologists, the intensivists. It's been such a rich discussion of all the challenges we face. I'm going to shift gears just a little bit. We've looked at chasing down peripheral pulmonary nodules, and we've looked at chasing down pneumonias, which are challenging. We're going to move a little bit more towards the extrapulmonary forms of tuberculosis to the mediastinal nodes and some of the pleural nodularities. But I'll start with giving a perspective on one of the oldest diseases that's been our bane. So we'll look a little bit at the problem statement of tuberculosis, some of the diagnostic and treatment challenges, what are the policy and healthcare advocacy efforts that we can take up. And we'll look at it from a global and local perspective. So let's not forget that while we treat each patient and each individual condition, we are part of a whole, and every action that each of us takes as a physician, as a pulmonologist, has an impact on our ability to be able to end TB, if that's a realistic goal. Where do we stand today? Right now, India is the hotspot for tuberculosis in the world. We lead in the number of cases in terms of the one country contributing the largest number of cases of tuberculosis in the world. We also lead in the number of MDR-TB cases. So this isn't something that we can get over with the stated goal of end TB by 2025. Does that mean we lose hope? No. We forge on. We figure out how to recalibrate the path to that. Where do we stand right now? 2.7 million. That somehow doesn't sound as scary as 27 lakh for me. Okay, so the larger number is scary. They've done surveys on how much is latent TB incidence in India. So that's 226 per 1,000. If we are 400 people in the hall, now figure out how many of us are actually latent TB positive right now. There are certain predisposing factors. We know that there are certain things that we've noticed in epidemiological studies, a male preponderance, the social factors that contribute to it, poverty, smoking, alcohol, and a rising number of drug-resistant tuberculosis cases in our country. I think it's an underestimate. What the last number says that 2.8% of new TB cases and 12% of previously diagnosed, treated partially or not TB cases could be drug-resistant tuberculosis. This varies from region to region. There are some states and some cities which have higher incidence of multi-drug resistant tuberculosis as a primary diagnosis. Those are the states that need to focus a lot more on their policies and all their programs. Look at where we stand in terms of tuberculosis as a cause of death in low and middle income countries. Amongst infectious diseases, if you did the same calculation in 2019, tuberculosis would be the #1 infectious disease causing deaths around the world. It's only after COVID that you have something that takes the place of tuberculosis. So it's been a pandemic which has been with us for centuries, and it hasn't received the attention that it needs. That's why they call it the captain of the men of death. Why is it the captain of the men of death? Because there's no access to healthcare in large parts of our countries. Most low and middle income countries have inadequate primary healthcare structures. There's misdiagnosis and misdiagnosis. Dr. Lokesh Gupta showed a case of a patient who had been treated with ATT for several months and the diagnosis was completely different. That's not an unusual case. You see somebody with a radiological finding and some symptoms that fit in, and that patient got ATT. You know, that seemed alarming to us. What is even more alarming is the number of patients who will go to a primary care doctor, say they have fever, cough, night sweats, anorexia, weight loss, and not be tested for tuberculosis. So that's an even scarier thing, the number of missed diagnoses. You have misdiagnosis and you have missed diagnosis. You have inappropriate treatment in terms of the drug combinations given or the duration, and an inability to complete the treatment because of adverse drug reactions, because of drug resistance, because of many social factors. We'll look at some of them. So if you look at variations in the quality of tuberculosis cases, this is a study that was replicated 10 years apart. If you looked at the early 2000s, they did this with standardized patients. These are actors who have been trained to present as patients with tuberculosis. They will go to a private practitioner's office, or they'll go to a medical college or a district hospital and say, I am so and so, I have these problems, I have these symptoms, let's see what the doctor says. And these are standardized interviews that are conducted with standardized patients. 20 years ago, the data showed that less than 30% of those patients got the appropriate referral to test for tuberculosis with classic symptoms of tuberculosis. You look at it now, this is, I think, data collected between 2015 to 2014 to 2017, something like that. 2 cities, Mumbai and Patna, 2,652 encounters, 1,203 facilities, including public and private healthcare facilities. Only 35% of patients received the standard of care, meaning were they being asked to get a chest x-ray? Were they advised to get a sputum test done? Were they referred to get a TB gene expert done? Were they asked to come back? Were they given unnecessary antibiotics? Were they given a quinolone? So many things that went wrong in each of these patients. Only 35% of patients today are getting appropriate treatment. We need to do something about that. What about the diagnostic gap? This is a lovely article. I would definitely urge you to have a look at it. It's a very small commentary. It's written by Dr. Madhupai and Dr. Soumya Swaminathan, who was the chief scientific advisor to the WHO and now is a principal advisor to the National Tuberculosis Program as well. And it looks at the way we need to move from microscopy to molecular diagnostic, from centralized lab-based nucleic acid amplification tests to more point-of-care testing. And you know what has happened is that with COVID, access to these testing modalities has improved. You couldn't have imagined before 2019 that a TrueNat testing facility device would be available in a remote district or primary health center in Nagaland or in Assam or in Jharkhand or in rural Tamil Nadu. Now it's there everywhere because we made it available for COVID testing. The main thing is to weaponize the existing facilities that we have and use them for testing for multiple medical problems. So we move from doing using devices only for one particular infection and trying to get the technology in every place to test for multiple different conditions that a population could have. The turnaround times have improved. I don't need to expand much on this. Everyone in this audience is already aware that we do not need to wait any longer for the number of weeks it used to take for cultures to come back for phenotypic drug sensitivity testing. That being said, those tests still have a role. So test as much as you can. If you have the facility for a CBNAT or a TrueNat, that is what we should be gunning for. Any of you who are private healthcare practitioners should know which is the nearest lab and facility which can get you the quickest turnaround time for your patient. Because it matters to our patients. They travel long distances to come to us. Telling them that they have to come back after several days, they may not come back. They will be lost to follow-up, like those 70% of patients who are not getting adequate care. So connecting with your local microbiologists, pathologists, radiologists is very important in private practice as well. And now we need to think of taking the test to the community. These are measures that were taken you've heard about screening for lung cancer in the NHS with taking large low-dose CT scanners to parking lots of shopping malls. Well, the same kind of thing could happen for TB too. There are certain partnerships. Dr. Banali Datta, who has been part of one of the initiatives of taking mobile chest X-ray, digital X-rays to villages, to places, and having the test taken to the people. So taking the testing to the community will help us do more active screening for cases. Operationalizing more adoption of TrueNat testing. This is actually a study from Andhra Pradesh, where training laboratory personnel in using TrueNat. And I have to say that we really need to make a bigger push for this, because even after implementing it for the last few years, the testing using TrueNat has only gone up from something like 15% to 19 or 21%. So it literally has to be a big push that every patient, you're trying to get a TrueNat done or a CBNat done as early as possible. So I'm going to show you a few cases. You've just had a discussion, a wonderful display of cases by Dr. Rajadhar. So won't take too much of your time with cases, but these are the kind of patients who deserve aggressive testing for tuberculosis. So a 65-year-old lady with diabetes, blood pressure, diagnosed with CA breast. She's operated, she's following up with chemotherapy, doing well, and then develops cough and some mild weight loss over a couple of months. A PET CT is done, reveals FDG-avid mediastinal lymph nodes. When we do a bronchoscopy and an EBUS, in any patient where I'm doing a bronchoscopy and an EBUS, who has a known malignancy and who has new PET positive FDG-avid lymph nodes, I don't just keep the possibility of advancing malignancy in my mind. I'm looking to get enough tissue to run the markers for the cancer, as well as looking to get tissue to send for microbiological analysis. So we got, you can see some of the material that we got from the lymph nodes over there. Luckily enough for her, it was necrotizing granulomas and it was gene expert positive and it was RIF sensitive. In the past, this kind of a patient, PET positive lymph nodes, after having been on treatment for 6 months, older woman who had a breast conservative surgery, would have been assumed to be advancing malignancy and not receive the appropriate treatment. Treat every new FDG-avid lesion, chase it, and diagnose it. I've had a patient who had a single solitary liver lesion, which we went in with a USG-guided FNA, and that turned out to be gene expert positive. So solitary lesion as well. Just every new PET positive lesion, try and chase it down. Another sad story of a person with a fever of unknown origin for 1 year who had been tested left, right, and center at multiple places across the city, comes to us. So 1 year of a fever of unknown origin, worsening over the last 5 months in weight loss. PET CT shows enlarged mediastinal lymph nodes, so much larger mediastinal lymph nodes, early basal ILD. The referring physician thought sarcoid more than anything else. He was referred to us for an EBUS TBNA suspecting sarcoid. I discussed EBUS with him and this gentleman broke down. Just look at his past surgical history. He spent a lot of money on many surgeries. He's at the end of his tether. He doesn't have any financial reserves left. We read the PET CT report in detail. There is a small sub-centimeter left supraclavicular lymph node with an SUV of 4. Palpated, couldn't find anything. Asked my radiology colleague to do an ultrasound of the neck. It's kind of really close to one of the vessels, main vessels, but he said, I'm going to try and get you material. The radiologist chased it down and we got it with just an ultrasound guided aspiration of the lymph node, costing the patient a fraction of what an EBUS would have. He's doing really well on treatment right now. A young woman with right-sided chest pain, a little breathlessness, reduced breath sounds. Look at her weight, she's 33 kgs, her BMI is 14.2. She had a pleural tap elsewhere which was inconclusive. We did a pleuroscopy with a biopsy. You see the classical appearance on the pleura. RIF sensitive, started on treatment, develops drug-induced liver injury, uric acid levels are high, lots of side effects. We had to keep pausing, readjusting her medications. Over time, she starts tolerating the medications. She's not febrile, she's holding okay, but there's no weight gain. Focused on her nutrition, right? And now she's picked up weight, it's 4 kgs more. We look at all the nutritional deficiencies these patients have. It's not enough to just correct with antibiotics and things. It's really about also making sure that her chances of recurrence, reactivation come down. So at the time when I'm finishing treatment, I also focus on telling the patients about how they will try and ensure that their immunity stays good. Sugars to be under control, weight, protein supplements, whatever. Nutritional supplementation has actually been studied on a public health platform. So this is a study which looked at giving rations, giving food supplies to families which have patients with tuberculosis. Because we know that the chance of a household contact of an open TB case developing tuberculosis is high. And it is most common in the rural and underserved areas that you'll also see malnutrition. You see a picture of me over there that is from Udaipur. So Basic Health Services is a rural primary healthcare program where they take the healthcare to the tribal communities. So you see what a typical clinic there looks like. This is us outside an Anganwadi clinic. You look at this lady, she's pregnant. Her hemoglobin is 6. Her arm is the size of a small child's arm. And these are the places where we really need nutritional interventions if we are going to make a bigger push to end TB. So don't ignore the nutritional aspect of tuberculosis. There's so many reasons for non-adherence to medications, the side effects, forgetfulness. I'm going to come to the last reason, and this has hit India hard in the last 1 year. Medicines being out of stock in our national programs. It has happened. All of us must be attentive to this. As a community, as physicians and pulmonologists, we cannot let this happen. That our national programs, where the poorest of the poor get their treatment for free, are only getting 2 drugs instead of 4 drugs. We are building the antimicrobial resistance in our communities if we do not use our voice and platforms to try and overcome that. We have to look at improving logistics of access to healthcare. There's newer technologies that have helped. There is the e-Nikshay platform, which has helped private practitioners also register all their cases. We are improving our data in terms of counting the number of cases. These are the recommendations that are there to try and ensure that our patients stick to their treatment, complete their treatment. It needs a lot of shift from our attitudes. If you feel that you're burdened, please do refer the patients to the national programs. They do a great job of it. But be aware of all the measures that we need to take to help patients cope with the adverse effects. Those of the patients who are going through drug-resistant TB face terrible adverse effects, and it needs an empathetic physician along with it. Nothing about us without us is a line that is used by many marginalized communities who do not receive the care they need from our national healthcare services. This is a program platform. You can find it on YouTube, Survivors Against Tuberculosis. Listen to the stories of how we went wrong as healthcare providers and did not provide support to patients with drug-resistant tuberculosis. You will find something in your practice that you can change in order to have more adherence, better completion, less drop-offs. I'm going to also suggest this book called The Phantom Plague. It came out during the COVID-19 pandemic. It tells about how tuberculosis shaped history. It also tells how history and geopolitics shaped tuberculosis. Our world is unequal. We live in a medical apartheid world where the drugs are developed, where the disease is not. I've included this of the coming of age of bedaquiline. Bedaquiline came in 2005 as a novel drug. Now is when it's found its place in a national program. Imagine 20 years. It could have been part of our national program earlier. There's a lot of geopolitics, a lot of intellectual property, and a lot of negotiation of trade deals with pharmaceutical companies. As physicians, it is our responsibility to also advocate for getting the better treatments available to our patients. We know now, August 2022, the TB practical study, the Zenix study in December 2022, that's made a WHO push for the shorter 6-month bedaquiline, the BPAN regimen with bedaquiline, predominant, and linezolid with either moxifloxacin and another one with clofazimine. Those were the ones that were studied. This is part of our programmatic management, shortened duration regimens for drug-resistant TB now, and we should be advocating for all our patients to have access to it because we know that it is more efficacious. So educate yourself, find out what the resources are in your communities. How long will it take to actually end TB? It's a grim future. When we say there's clinical deserts, there's parts of the country which have good healthcare, there's parts which don't. We need to make uniform and universal access possible. We are facing an antibiotic apocalypse. There aren't too many new antibiotics in the pipeline. You've seen bedaquiline come out as a generic now, and you might have met people who are pushing for it. We need to make sure that every usage of antibiotic is appropriate. Kerala has made an initiative that every antibiotic prescription filled out by a pharmacist must be registered. We have patients who go to the local pharmacy and say, I have a fever and a cough and I'm bringing out yellow sputum or I'm coughing up blood, and the pharmacist will give them 5 tablets. They don't know what it is, we don't know what it is. So far, the short durations are only applicable to people who have had less than 1 month exposure of bedaquiline. If access to all antibiotics becomes free for everyone, we will be facing another drug resistance nightmare. Right now, where we stand is the cost is extremely high. If everything continues, it's going to take 130 years to end tuberculosis. How do we shift that number from 130 years to something maybe within our lifetimes? It's by forging public-private partnerships. And that has really made a shift. I don't want to end on a grim note, but if you look at what's happened with public-private partnerships now, there's been an increased number of patients seeking care in the private sector. From 2017 to 2021, the success rate of TB treatment in the private sector has gone up from 38% to 82%. About 35% of patients who took TB treatment last year got it from the private sector. The reporting onto the national platform by the private sector went up from 67% 2 years ago to 89%. So the private healthcare sector is coming up to support as much as possible. This is going to be the way of the future. TB will have to be something that each and every one of us works towards. We have to be a problem solver. How can we help? Test, test, test. Antimicrobial stewardship. Your best friends are your microbiologist and your pathologist. Document everything. Get onto the platforms. Upload your patient data. Spread awareness in the community. Write when you get a chance in every newspaper on every important day. And never doubt that a small group of thoughtful, committed citizens can change the world. Thank you. I also wanted to just highlight that never doubt a small group of thoughtful, committed citizens can change the world also applies to the people who are fighting to end or bring legislation to protect doctors from violence. So, thanks.